For anybody new, I do see some new faces. So I'm going to encourage people to read the bios because I'm going to do a brief introduction because they have picked the best of the best, the cream of the crop to come present to us today. And I have the opportunity of introducing Dr. Misty Shields. She is the Assistant Professor of Clinical Medicine at Indiana University School of Medicine. Let's give her a round welcome.
Good morning. Is everyone able to hear me before I get started? Okay. Let's see here. Oh, no, you're fine. So I'm Dr. Misty Shields. I am an assistant professor at Indiana University. I'm a thoracic medical oncologist, and I'm here to talk to you about the development of a longitudinal liquid biopsy program for small cell lung cancer. So as you all know, there's nothing small about small cell. We know it was deemed a recalcitrant malignancy of the lung by the NCI in 2012. And the heterogeneous biology of small cell is what drives potential chemoresistance after the initial carboplatin etoposide that we all know. And despite a lot of the advances we've seen, a large number of patients do succumb to the disease early. And so breakthroughs are desperately needed. I think it's powerful to know, the landscape it was and the landscape it now is. Platinum etoposide in the 80s beat out a multi-regimen that was very toxic called CAV, cyclophosphamide, adriamycin, and vincristine that had been the standard. And carboplatin was just as effective and less toxic, and so it became the standard in the mid-'80s for small cell lung cancer for both limited and extensive stage. And then in 2018 and 2019, we saw the back-to-back studies with Empower 133 and Caspian adding the addition of immunotherapy, really starting to see a breakthrough of hope. In 2020, lurbinectedin received FDA accelerated approval as a second-line and beyond option. And now we're really seeing a lot of exciting drugs on the horizon for small cell, including tarlatamab, the BI compound, as well as some pretty neat antibody drug conjugates, IDXD, as well as sacituzumab govitecan. And we just heard, last week, the Adriatic press release with an overall survival benefit for limited stage by the addition of immunotherapy after chemo and radiation. So we haven't gotten to see that data yet, but it is coming. The fight for me against small cell is personal. My dad, whenever he was 48, was diagnosed with small cell. I was 13 at the time. My dad was a Marine. He was a veteran in the Vietnam era. He was an electrical engineer. And he was diagnosed after a pneumonia that wouldn't go away. And so being the strong Marine that he was, I have a couple up here I knew. We said we were going to fight this and put it away. We didn't tell anybody. We fought this all alone for a year and a half. He went to MD Anderson for trials. He had radiation to the brain, and he passed in October in 2000 when I was 15. And it was there. Yeah. Thank you so much.
Sorry for the interruption. This is why we wanted her to be here, though.
Sorry. And it was there in the hospitals at the VA in Dallas that God placed on my heart that this was what I was meant to do. I didn't know how to get there, but I knew that something needed to change. To have families have their loved one for longer, to give hope, to be kind, to show empathy, and to end stigma. The number one question I get is, if I tell my story, is did he smoke? That's the number one response I get. And how unfair and how unkind. And does that really even matter? He did barely, but he was in the Marines, and he was exposed to a lot of radiation as a radar technician in the military. But does it matter, right? Everyone's life is important. Everyone matters. We treat everybody the same. And to never stop fighting against this awful disease, right? And so to help end lung cancer now. And so it was placed on my heart to become an oncologist, and I had no idea how. This is back in the AOL days, before Google. I had to use a CD to get hours to get online, and so I found, living in Dallas, growing up in Dallas, that a world-renowned thoracic translational oncologist was right in my backyard at UT Southwestern, Dr. John Minna. And if you don't know his story, he is the oncologist that founded over 500 cell lines that we know, and how we have discovered everything we know about lung cancer, about PVD3 and RB and MYC. He created all of these from patients he saw at the NCI in the 70s with his best buddy, Dr. Adi Gazdar, a pathologist. And that's how we know everything we know about lung cancer and about small cell today is all of his work, his legacy, his giant contribution to oncology. So what we know about lung cancer is what we know about cancer because of him. And he just happened to have been transferred to Southwestern a few years prior. And so I reached out to him and asked, how do I become someone like you? How do I become an oncologist? And he told me, get good grades, go to college, and maybe come and, rotate in my lab sometime, come join my lab sometime in the summer. So I took my journey, and that's me in college, right in the top left. I went and studied biochemistry and genetics and double majored at Texas A&M. I worked in a research lab all 4 years of college, and then I applied to graduate school just at Southwestern and joined his lab. I did my PhD with him at UT Southwestern. You can see there in the second picture, he's there on the left. And while in his lab, we had a collaboration, and we studied small cell with Dr. Melanie Cobb, one of the National Academy of Science members. And it was there that we discovered the second neuroendocrine subtype for small cell called Neuro-D. I went on to, I told him I want to serve at the bedside, I want to see patients. And so I went on to medical school at UT Houston, which is affiliated with MD Anderson. Then I went to my residency at Vanderbilt in Nashville, Tennessee. You can see my two children there I had as an intern and as a third year. And then I went on to fellowship, where I was chief fellow at Moffitt Cancer Center and worked back in a research lab with Dr. Uwe Rix. And so I joined faculty at Indiana University in the fall of 2022 and established my research laboratory, the Shields Lab, where we focus only on small cell lung cancer. I have a technician and a graduate student and a couple of other students rotating. And so our vision is to limit the suffering and devastation that small cell causes to families and patients. And our mission is many-fold, and you'll see that here. So there's many ways that we can approach small cell, and one I would like to focus on today is something affectionately called macros, or a longitudinal liquid biopsy program that I established at IU. What we know about small cell, and this is the work that was initiated by Dr. Minna and Dr. Adi Gazdar. This was a study presented in Nature in 2015 by Dr. Julie George and a lot of the giants, Dr. Govindan and all of the giants of small cell. These are each individual patient tumors, looking at the mutations that are in small cell. And not every small cell is not the same. It's not one size fits all. But it has been treated that way for so long, and that's what we have to change. We know that small cell derives from neuroendocrine stem cells in the the central airway, and those are initiated by loss of two very important tumor suppressors that help protect these cells and allow them to go awry and form small cell. As mentioned, we know that oncogenes are a little bit different in small cell than we see in non-small cell. We see that it's not EGFR or ALK or ROS1 or KRAS like we see in non-small cell. It's not mutations where something is broken and it's addicted that way. I like to think of it as like a car, and the volume is turned all the way up on blast. So that's what these are like. These are transcription factors. These are super enhancers. They turn on cascades of many pathways. So it's like that volume is turned all the way to full blast. It's not that the button's broken. It's that it's stuck on that on position and on very loud. And so how do we target that? How do we understand that? What is that? Why is that important? And so we knew about one of these back in the early 90s, and then our group, along with Dr. Melanie Cobb, found NeuroD in 2013, and that led to the several others that have been identified. You see with YAP1 and PALTO3 and Carl Gay's work with the inflammatory subtype. And so all the kind of giants of small cell got together and said, maybe it's time to think about small cell not as one size fits all, but as these neuroendocrine subtypes. And so we started to think of the things in small cell as more of these neuroendocrine subtypes than a certain one size fits all. And so we're able to actually find these and test them in tumors and test them on the biopsy samples that are performed, when you have an initial biopsy. And so we can characterize what subtype or what number of subtypes, sometimes they can be mixed, what those look like. And so that was actually published a few years ago out of the group out of Memorial Sloan Kettering. But you can't have knowledge of the tumor after it comes back based on the initial biopsy. And so how do we study this over time? And so one way is the evolution of something called liquid biopsies, which is just simply a tube of blood or 2 tubes of blood or 3 tubes of blood taken from a patient when they're seen in clinic, and that can be studied for either DNA, RNA, or different pieces of the tumor that are from the DNA from the tumor that goes into the bloodstream, not necessarily tumor cells. And we know that these have been able to show, being able to kind of predict who might have their disease come back or certain alterations and how it changes over time. I know Dr. Simon Heek is here, and he'll also be speaking on some of this as well. And so we can detect these subtypes by the circulating DNA that's in the bloodstream. And so the group out of UK with Memorial Sloan Kettering did just that. But there's a lot of unanswered questions. So we know that the disease changes from day one to if it comes back. And so how do we pivot? How do we change with the disease? How do we know when to test? And what is the cadence? Is it at, when the patient is first diagnosed, or is it over time? And is this something that we can help do more treatment options for patients? And so that's where I came up with the idea for macros, which is mechanisms of acquired chemoresistance for oncology for small cell. And the idea is to learn just that. We take a few tubes of blood each time that we see a patient, and we study that, and we can look at all the expansive genomics of the tumor and figure out, what is changing over time. And so this is the design. Running out of tissues here. So any patient that comes to our clinic at Indiana University is approached to be enrolled on this study. And so we are just at IU currently. And so patients are approached and consented. And if they agree, they will have 3 tubes of blood drawn before they start treatment, and every time you get scans. Right? So every 6 weeks or every 9 weeks, every 2 months, every 3 months. And we follow the patients, and we follow them wherever they're at. Any patient with small cell is approached, whether they're limited stage or extensive stage. We have an opportunity to learn from every single patient. Right? And so we collect these tubes of blood. They're all de-identified and stored in a standardized fashion. They're labeled with a different label, so it doesn't have your name on it, and they're stored in long-term storage for these analyses. So this takes a large team to do this. So I have my team with BC Squared, who's the repository group at IU. I have my clinical pharmacist, a medicine resident I work with, our cores, as well as collaboration with, I think you all heard Dr. Chaparna Sen yesterday, as well as Dr. Max Dean. So we launched in March of last year, and we started enrollment in April, just 1 year ago. And since that time, we have 30 patients on study who have been enrolled and collected, and we follow them throughout their journey. And so if they have side effects to therapy, we annotate that. If what their scans show, we annotate that. Everything, all those pieces matter, right? And so we've had 30 patients enrolled. We've had 75 unique collections and over 200 tubes collected that are then microaliquoted. We are able to do the, thank you. We are able to do the neuroendocrine subtyping on tissue. We have validated that at IU. And we are able to follow all of these patients. And so we have a quick output, which is looking at the circulating tumor cells from each of these patients. But the bigger output is all the genomics, the DNA, the RNA, the methylation, what genes are on, which genes are off, what's the subtypes, all of those come a little bit later. And so each of these you can see here are unique patients. These are each patients. You can see it's not projecting as well, but they are color-coded. And so you can see patients over time. What we know about small cell is that it has a proclivity to spread. And so if a patient's diagnosed with extensive stage, they are more likely to have tumors in their bloodstream that we can study or capture. And you can see that here with some of these patients with over 10,000 blood tumor cells in their blood. You can see that for the majority of patients with treatment, that rapidly goes down. Not sure if this projects here. Yeah. So you can see like the patients here, this is one single patient, and we can follow, you can see these patients, they rapidly are able to clear the amount of circulating tumor cells with their treatment. But that is not enough, right? We have to know who those remaining cells are and why they are still there, and what can we do about it. So I want to walk you through, this is a lovely patient of mine who presented actually to the ER. He had shortness of breath. He got a chest x-ray and ultimately a CT scan in the ER, and was found to have a very large 9-centimeter left lung mass. He was actually erroneously discharged to see surgery. And I saw his chart and said, no, this is not appropriate. He got a biopsy, and it came back initially as a poorly differentiated carcinoma, and then on further clarification was small cell. And so we started him on treatment that week. With carboplatin, etoposide, and atezolizumab. And you can see his baseline, right? He had a lot of circulating tumor in his bloodstream, but he was able to clear that, 3 log fold with just an initial sets of treatment. He did wonderful. His tumors shrank beautifully. He felt well. He has lovely family. He lives alone, but he had his brother and his sister-in-law helping and taking him to all his appointments. He actually kept all of his hair. He had very longer hair than me. And so, as part of that, we continued to obviously see him, and we switched him to just immunotherapy alone after 4 cycles. After 3 doses of immunotherapy, his disease tripled in size. Right back to almost a 9 or 10 centimeter tumor. He felt short of breath. He felt unwell. And you can see that here. Right here. Right. Corresponding to his scans. We started him on lurbinectedin. He immediately felt better. You can see here. He was able to clear his bloodstream of all of those circulating tumor cells. But then something changed just after 3 cycles of lurbinectedin. He again felt short of breath. He came to see me. He did not appear well. He was in a ventricular or an atrial fibrillation with a fast heart rate. And we were trying to get him on one of the DLL3 studies, and unfortunately, he screen failed. And so after many conversations, unfortunately, he was not well enough for treatment and did enroll in hospice. Despite all of his best efforts, despite everything in planning and doing very well, he unfortunately, has succumbed to having small cell. And so, what happened? What changed? Right? What is this disease? Why are some patients sensitive and some patients have very resistant tumors? And that's what we need to learn. Every patient is unique and every tumor is unique, and we have to learn from it. And if we don't capture this information, how will we ever move forward? And so that's exactly what we're doing. We are sending all of these samples for analysis now to Van Andel, which is based in Michigan. And we are looking at the subtypes by a diagnosis across time, looking at all the signatures, what's up and what's down. Are there genetic changes? Is it all RNA? Is it protein? What is it that we're missing? And so that is underway, and hopefully you'll be hearing from us soon. And so, we are interrogating these mechanisms to try to figure out what it is within a patient, within groups of patients, right, within patients throughout their course. So hopefully more to come very soon. And finally, in closing, I want to introduce a advocacy group that I have launched through Indiana University. I do encourage you all, if you have a Twitter or an X account, to join. I want to hear your voices. I want to know. This is going to be housed at Indiana University, but we have a partnership that is to soon be announced for launching internationally. And we need to hear your stories, your voices. And so we'll have local events at IU, but hopefully we can have additional events outside. So this will be housed underneath our End Lung Cancer Now advocacy group as a small cell focused patient support group. And so our goal is to build a community for support, to raise awareness for research, screening, and lung and stigma for small cell or for lung cancer, and to spread hope. So I encourage you, if you have a Twitter account, to follow us and interact and let me know how we can help. And with that, I'll close, and I'm open to any questions.
That was incredible. Thank you so much. Thank you so much.
This is great. Where are we in the phase of being able to get a liquid biopsy for the initial diagnosis? And is it in like a clinical phase trial or anywhere?
Yeah, so there's a couple different things. So I do sit on the National Comprehensive Cancer Network, our panel for small cell. So there's 32 institutions, I think 33 now. And so I know also Dr. Jacob Sands does as well. And so as part of that, we did discuss what the role of these liquid biopsies are, at least in the current platform we have. And I would encourage you or any of your friends or anybody that you see in a clinic, every patient should have a liquid biopsy from the commercial platforms at least once. It is recommended, it's approved, it's in our guidelines as of August this year, that you should be at least tested for the genetic portions of it at least once to know if there's any other rare fusions or genetic mutations that are there. And so to help with any trials or guiding treatment, we do see that, and it can impact the patient's outcomes. I actually reviewed a paper about a year ago called The Lazarus Effect. I was one of the reviewers for it, and a patient had a RET alteration, a RET mutation, was in the ICU and was found to have that placed on a therapy and is now alive and doing well, now over a year, I think, and a half out. So it matters, and it is in our guidelines that you should not be charged for that. In terms of at diagnosis, there's been some investigational studies looking at, for patients, especially like if you're getting a lung cancer screen, a CT, there was a study called Delphi that looked at if you could test the blood for certain neuroendocrine subtypes. And so actually they were able to find, I think, 12 out of the 13 patients who had small cell by that blood test. But it's not ready to launch into practice yet. But I think it is getting there, because if a patient has something pop up on a lung scan that's a tiny nodule that they're going to opt to wait, that might be different in 2 months or 3 months whenever it gets repeat scanned. And so that's, I'm hoping, a direction that will start going. Absolutely. The power of just having a few tubes of blood can tell a lot of information.
Is anyone here from Indiana or living in Indiana? Okay. No, go ahead.
First, thank you for being here and sharing your story. It's very powerful for us to have somebody that has such a personal experience in translating that into this field of work. So thank you.
Thanks.
My question is the study that you have for macros. Mm-hmm. Is there a national database that catalogs these studies throughout universities, like we have the National Clinical Trial Database?
So in terms of available databases, a lot of what we know are, unfortunately, in the cell lines. There's something called small cell miner, which is a big database, but that's all based on the genomics, SCLC cell miner, MINER. And it's a publicly available portal, and you can look at different genetic things. It is all based, it's, I think, 7 different institutions, including the Broad and MD Anderson and Southwestern, and so that does have data on the genetics or methylation, but it's all based on the cell lines. In terms of patients' available data, what we know for the most part, and I know Dr. Heek's going to be speaking as well, has been on initial tissue or very rarely on rebiopsy, which is not very common, unfortunately, in small cell, because it, that can delay the treatment that patients ultimately need. And so there's not yet, I think, an available database for this. I know there's like CBio portal in different places, but I think this small cell miner is probably the most available, but it is in cell lines that were established from patients. Yeah.
Any other
I want to
questions?
say thank you for being here also and giving y'all your information. It's helped a lot. I kind of have a biased question. Have you ever treated or seen anyone with extrapulmonary small cell? What's the difference between that and non?
Yeah, so there's 2 other categories, right? Extrapulmonary small cell is one, which is a small cell cancer arising from an area outside of the lung. And then, there's also transformed small cell, which is arising from another type of tumor that can turn into small cell. And so I think it teaches us a lot about the the underlying biology, which is typically from those two genes, that P53 and RB, that can potentially lead to very similar genetics and biology as small cell that arises from the lung. So I do have several patients that have extrapulmonary small cell. One of the studies, the Darion-5, which is the DLL3 bispecific T-cell engager, actually has a specific cohort for patients who have extrapulmonary small cell, who can be treated in second line and beyond for that study. And so I think there's what we've known about, because it's so rare, we extrapolate a lot from small cell and what we've learned and gained from small cell to the extrapulmonary small cells. We commonly see it sometimes in like the prostate as another place, but we see it, in the liver or the GI tract or any other locations, the esophagus. So I do have a couple patients. We have to extrapolate our treatments from small cell lung cancer to that. And similarly, transformed small cell arising from something like ALK or EGFR, non-small cell lung cancer is treated also very similarly to small cell, a little bit different biology.
Thank you.
I don't have a question. I just want to make a comment. I truly appreciate your story, your personal story with your dad, and know that he is so gosh awful proud of you. And I want to thank not only you, but all the sponsors that are involved in finding cures for people like this. Thank you so much.
Thank you.
Hello. Thank you for sharing your story. It was very touching and personal to me, because when I was 11, my dad was diagnosed with esophageal cancer, and he died 1 month and 1 day after being diagnosed. So thank you for your fight. I just have a couple of questions. I actually work in clinical research, and just had a couple of questions about your macros study.
Yeah.
I wanted to know, is there any other, I know you do the blood draws, is there any other data that you collect on the patients? Are there any questionnaires that they complete to show any changes in lifestyle or environmental changes that may affect any changes in their diagnosis?
So, not currently. We are launching now into year 2, so we are making slightly a little bit of changes from what we've learned from year 1, but that's a great idea. We do, personally mine all of the charts. The part of my team, we go through and look at everything. Did they see palliative care? Did they, what toxicities from treatment? Have they been approached by tobacco cessation if that's appropriate, right? Mm-hmm. So we do go through those pieces. We don't. We try not to interface with the patients at all to try to not introduce any bias. Right. But we do, scour their charts. I will say one other piece that is important to me, that all of my patients I approach who have small cell, when I first meet them, is that they should have support through palliative care at diagnosis, regardless. No one deserves to walk through this alone. You deserve to have an extra set or sets of eyes that are looking over at patients who have early palliative care, not hospice, but early palliative care, live longer, stay on treatment longer, and are able to have all their symptoms, approached and addressed early, and they stay out of the hospital. And so because of that, I actually was able to integrate that into our guidelines at diagnosis for small cell last year. It's so important. You should not fight alone. Your friends and family deserve that support, and you shouldn't have to navigate with all those questions and have symptoms related to disease. That's what we're here for. You should have an additional layer of support from your team, not less.
Awesome. A couple more questions. For the macro study, was that just in your facility, or were you collecting data from patients sort of all over to give you a good, can't think of the word, but a good analysis of people in different areas versus just concentrated in one area?
Yeah. So currently we are just housed at IU Simon Comprehensive Cancer Center. My dream is to make this a registry.
It should be.
That's my dream. I think that this should be something national. It's a lot of red tape to get there. I'm trying to break through that. But the idea would be that this is a registry that patients sign up for, and we can follow any patient over their course through their journey. And so, of course, I can't use any of this information to inform my patients of, hey, your numbers jumped up.
Right.
I have to remain, with equipoise. But I think it would be powerful to help get over those barriers that we don't know about how the disease changes if it comes back in a patient. So that's my aspiration, is to get to a registry.
That would be awesome. To have a registry. The last question that I have, and then I'll turn it over. I know that immunotherapy is something that we're looking into, seeing how it is helping with the disease and diagnosis. Are there any other measures that are given to patients? Of course, I know getting this diagnosis can be devastating, but are there any other lifestyle changes or anything outside of anyone that's smoking? Of course, smoking cessation, but is there anything else that is promoted for the patients to help to go along with the treatment that they're receiving for longer life? Yeah.
So two things. Two things I like to do with all of my patients who have small cell. Right now, it's only in the patients who have extensive stage, but I do have a clinical trial that G1 Therapeutics is going to be supporting for limited stage. But number one is a drug called trilaciclib. It's an IV medication. I don't know if anyone's received it, but it's a supportive measure that was approved by the FDA a few years ago, and it's actually reimbursed by insurance. It's given before each day of infusion for day 1, 2, and 3 for extensive stage, before carboplatin, etoposide, and immunotherapy. And what it does is it freezes the immune cells in the bone marrow, the red cells, the white cells, the platelets, so that they don't get exposed to chemotherapy like all of the remaining cells are. And so it freezes it for about 24 hours and it then allows them to kick back in. And what we see is that patients, it's FDA approved for this indication, that patients need less blood transfusions, they have less delays in therapy, they stay out of the hospital, they stay on treatment, and they require less dose reductions. And so all of my patients are given that, unless they live very far away, like in Bloomington or something, and it's just too burdensome to come 3 days in a row to the cancer center every 3 weeks. And so every patient should be at least considered for that. It's given 30 minutes before all your pre-meds, and it's just an IV. If you give it in D5W, it's a lot easier. It can be given peripherally versus with the report. And so that's one that's billable by insurance and should be covered and no cost to a patient. And so that helps prevent, really bad infections that may get you hospitalized, as well as preventing blood transfusions of blood or platelets. And so that's one. And then the second thing is to have patients rehabilitate while they're on therapy. We call it pre-rehab, which is getting patients into PT, OT, PM&R early, so that, if they have a neurologic deficit from a brain metastasis, we can help work them through that while, to regain their strength or to maintain what strength, they may have, or if it's pulmonary rehab, getting that patient early into treatment while you're going through it to get ahead of it, to maintain that fitness. And then, of course, nutrition. Every patient should see an oncology dietitian or nutritionist to help with high protein and support there. And so, we have to be ahead of this cancer and have to be ready if it comes back for round 2. And that's always my focus, is we have to be armed and ready and get patients in their best shape they can possibly be if it was to ever come back.
Thank you. And one brief question.
I know we don't have any time left, but so this might be an interesting way to close this, Dr. Shields. Dusty just reminded me, I've shown a couple people this. We told my 7-year-old granddaughter, who I'm like this with, that I have lung cancer in February. This last week, her first grade teacher passed out a paper saying, in 100 years, what my job will be. And she wrote, Cancer Awareness Podcast Host. You are the perfect person to be doing this research. And I'm hoping Dusty's right, and that in 25 years, it will be my granddaughter.